Let's start by talking about the treatment. For the treatment, although it's true that I reference both the latest British guideline from 2004 on the management of systemic sclerosis and the EULAR guidelines that came out in 2003, you might say that I've taken a mainly practical approach. What do I mean by practical? Well, we're going to focus on all the manifestations, but many of the things I'm going to talk about actually go beyond what's included in the guidelines. EULAR classifies in the latest EULAR guidelines from 2003. What they do is they define an immunosuppressive continuum, meaning the manifestations that are mediated by the immune system and therefore will respond to immunosuppressants, such as vascular manifestations, pulmonary hypertension, digital ulcers, and Raynaud's phenomenon. It's important to really understand the drugs we're going to use before discussing vascular involvement. Why? Because these are drugs that, in the day-to-day practice of a rheumatologist, we might not be used to using. And so, since we're not used to them, so I'm going to talk about them. What drugs do we use for vascular involvement? Well, first, we have 4 pathways to inhibit, mainly the hydroxygen pathway. It's important. If you're going to use a drug that inhibits the hydroxygen pathway, such as a phosphodiesterase inhibitor, type 5, that is afilofafil, or a stimulator of soluble guanylate cyclase, like riociguat, obviously you can't combine them. You have to switch one for the other. If we move on to the endothelin pathway, which is a very potent vasoconstrictor, we block the receptor. This results in vasodilation. We have antagonists of this endothelin receptor, such as bosentan, macitentan, and ambrisentan. Then the prostanoids, which correspond to the prostacyclin pathway, we have intravenous prostanoids, the only inhaled one, which is treprostinil, and the oral prostanoid, which is selexipag. Then it's true that recently this drug has been introduced, which is sotatercept, from the activin pathway. It's not a vasodilator per se, it's a different pathway. Just so you're aware that it exists. But we must not forget that when it comes to managing vascular involvement in scleroderma, the first line of treatment, they are going to be calcium antagonists that I am not going to go into detail about because we already know them. So, management of Raynaud's, first line, oral dihydropyridines, especially in clinical practice nifedipine in extended release form, which is the most affordable, sometimes combined or not with topical nitrates, such as rectogesic. Don't confuse it with Emoil, which is a vasoconstrictor. It's a completely different ointment from phosphodiesterase 5 inhibitors. In case there's no response to oral dihydropyridines, then sildenafil or tadalafil can be used. And then there are other pharmacological options, such as ARBs, which do have studies supporting their use in primary Raynaud's, not in Raynaud's secondary to systemic sclerosis, or prazosin. These would be the most commonly used doses. Above all, it's important to be clear that even if there's no initial response, we need to try increasing the dose up to the maximum tolerated dose. Tolerated, until we can truly determine that there is no response. And then don't forget about other non-pharmacological measures such as protection against the cold, as we all understand, with closed gloves. Not gloves with holes or wool gloves, portable hand warmers like the one shown in the image. Quitting smoking is important, managing cardiovascular risk factors, and also evaluating for secondary causes. In systemic sclerosis, a significant percentage of patients may have structural vasculopathy, as Pablo has defined, due to macrovascular involvement. Also, for example, involving the ulnar artery, which is also described in systemic sclerosis. Neuropathies like median nerve neuropathy, ulnar nerve neuropathy, etc. Toxins like vasoconstrictive toxins such as cocaine. Stress. There are indeed studies with fluoxetine showing improvement. Thus, patients with Raynaud's who are given fluoxetine show improvement in their Raynaud's symptoms. That is to say, stress is ultimately a vasoconstrictor. So that needs to be taken into account. When it comes to digital ulcers, we need to consider aggravating factors, as we've been discussing with Raynaud's, especially the appearance of ulcers in a very specific area. Here, as a first-line treatment, we would indeed use phosphodiesterase type 5 inhibitors. That is, we move on to sildenafil, tadalafil. It's important to remember that endothelin receptor antagonists, such as bosentan, have not been shown to accelerate the healing of ulcers, but they do help prevent their occurrence. Therefore, in cases of recurrent and frequent ulcers, it would be appropriate to introduce it. Also, in cases of ulcers that do not respond, in critical ischemia, etc., we would move on to prostanoids. And there are also recent studies with antiplatelet agents for ulcer treatment, which show improvement and accelerated healing of ulcers. As I said, ulcerative disease is a serious condition, so we have the option of invasive measures, such as sympathectomy and botulinum toxin. This is the algorithm proposed by EULAR, which I just mentioned. Basically, remember that as a last-line treatment, prostanoids are used, specifically iloprost administered via a 6-hour infusion. This requires hospitalization and the patient must be monitored. It causes hypotension, pain, discomfort, so both blood pressure and heart rate need to be closely monitored. Also, here, it's important to rule out local complications such as osteomyelitis. We must also not forget the role of nursing care. It is indicated in infected ulcers that do not respond to debridement, specifically not enzymatic debridement, but surgical debridement. In other words, we are going to remove slough with a scalpel, but we are not going to cut into the edges because, as we know, it's still a condition that won't heal easily. So, if healing is going to be difficult, you're not going to slice off the edge where the wound is trying to heal. Also, remember, I'm going back a bit. Remember, topical antibiotics are contraindicated due to the resistance caused by the biofilms that form. If infection is suspected, antibiotic therapy should be oral or intravenous. And then, importantly, pain management. And by pain management, I don't mean giving Nutil, I mean using opioids. Because the goal isn't just for them to be pain-free when touched, but for them to have no pain at rest. I mean, pain is still, as I say, and no one else is opening me up, a powerful vasoconstrictor, so we have to be controlling and aggressively targeting the pain. Obviously, consider aggravating factors for vascular risk, and then in cases of critical ischemia, if the patient is admitted, it's an emergency. Start heparin and intravenous prostaglandin analogs. Calcinosis. Same considerations as in patients with ulcers. We have both local treatments, such as neem oil and thiosulfate. For large calcinosis skin, we can use shock waves or surgical removal. And then there are indeed observational studies on systemic treatment with glycine, bisphosphonates, and rituximab. When evaluating pulmonary hypertension, I'm referring here specifically to pulmonary arterial hypertension. Why? Because we're going to focus on group 1 pulmonary hypertension. Therefore, we must not forget that pulmonary hypertension can be mixed. It can be associated with interstitial lung disease, group 3, associated with left heart failure, group 2, or thromboembolic disease, group 4. So that always needs to be taken into account, especially since it is common in systemic sclerosis. First, to treat pulmonary arterial hypertension, we stratify the risk. This was taken from the latest pulmonary hypertension guidelines in the chapter on pulmonary arterial hypertension, which includes connective tissue diseases. There are many tools to stratify risk. What matters to us is that it includes functional class, the 6-minute walk test, and BNP, which is the only biochemical marker that has truly been shown to independently predict risk. As I was saying, there are other guidelines that include cardiac markers, especially highlighting the REVEAL-2, but we won't go into that because it's not the focus of this talk. When it essentially pertains to treatment, once we've stratified the risk, we divide it into either non-high risk or high risk. And this will guide us in deciding whether to use a combination of 2 or 3 drugs. In non-high risk cases, as first-line treatment, a phosphodiesterase type 5 inhibitor and an endothelin receptor antagonist, that is, sildenafil. Then, moving on to what is considered high risk. In high-risk cases, we do need to add a third drug, meaning prostanoids. From there, we will assess the risk every 3 to 4 months. If low risk is maintained, which is our goal, we will continue with the initial therapy. But if not, we will have to add either prostanoids, which can be oral, such as Z-Pak, or switch the phosphodiesterase type 5 inhibitor for riociguat, which, as I mentioned, works through the nitric oxide pathway. We are not going to combine, we will switch or use the new drug that is not yet marketed in Europe, sotatercept. In cases of intermediate high or high risk, as I mentioned, intravenous prostanoids are recommended. In this case, oral prostanoids are not as strongly recommended, or sotatercept. And finally, in patients who remain at high risk, despite treatment, it is indeed indicated in the new 2024 guidelines. Quadruple therapy, that is, via the nitric oxide pathway, endothelin or prostanoids, and then adding sotatercept. Finally, note in pulmonary arterial hypertension, it is not indicated. In arterial hypertension, group 1 anticoagulants are not indicated. Correcting iron deficiency and anemia, and remember vaccines for respiratory infections. In these patients, pregnancy is contraindicated as it is very high risk. And then there are considerations regarding home oxygen therapy. What about the other groups of pulmonary arterial hypertension? Well, as I said, in group 3, it is associated with a poorer response because they have added ILD. Is there a need for immunosuppressants? And then also in this group, inhaled treprostinil is indicated, as this is a specific group in which it has been tested. In left heart failure, treatment will be focused on the underlying cause. Careful with diuretics to avoid triggering a renal crisis, depending on the patient's condition. In the case of beta blockade, an alpha-beta blocker is preferable to a beta blocker alone. And then there's thromboembolic disease, group 4. Here, anticoagulation is indeed indicated because after all, these are clots. In the case of large clots, the treatment will be thromboendarterectomy. But for distal clots, riociguat is indicated. Additionally, since this is a patient with thromboembolic disease, it's important to also rule out an associated APS, antiphospholipid syndrome. Regarding skin involvement, I've included a phrase I've often heard in my department, which is, don't give junk treatments to someone with limited disease. In other words, our treatment for skin involvement will be focused on the diffuse involvement. In cases of limited involvement, if it's very mild, like sclerodactyly and similar, you won't need immunosuppressants, or at least initially, the risk-benefit ratio isn't favorable. Obviously, in a very extensive limited form, then you might consider it. The treatment of choice is mycophenolate. I've included here the conversion between mycophenolate mofetil and mycophenolate sodium. What actually differs is the salt to which the molecule is bound. When I started residency, to be honest, I didn't really know the conversion. So that's why I've included it for you. First-line treatment then is mycophenolate, but an alternative is methotrexate, which is admittedly perhaps less potent, especially if there are other manifestations like skin involvement and so on, immune-mediated manifestations. It might not be the first-line option, but still, it's an alternative. Rituximab is also recommended in the guidelines. And also cyclophosphamide, especially the intravenous form, which, as you know, is less toxic than the oral route. But outside of the guidelines, there are indeed studies. Also with azathioprine, which show that when azathioprine is withdrawn, the skin condition worsens. So, in certain circumstances, such as pregnancy, it may be appropriate. Tocilizumab is indeed included in the guidelines, but in neither of the two trials did it show a reduction in skin fibrosis. However, EULAR does recommend it in cases of diffuse scleroderma with elevated CRP and positive antitopoisomerase. That is, a very inflammatory disease profile. And then also with immunoglobulins, although it's true that the trial at 24 weeks did not show any difference. In the patients who were followed up at 60 weeks, there was indeed a difference, so it is a safe alternative in cases of infection. For telangiectasias, just remember that the triple pulsed laser is the most effective, and non-laser light, intense pulsed light, has the fewest side effects. Moving on to the interstitium, as I mentioned, within this therapeutic continuum, mycophenolate would be a first-line option, as well as rituximab, which has also shown superiority, particularly the combination of rituximab and mycophenolate. Cyclophosphamide, which would require retreatment every 6 months because its effect only lasts that long, is therefore very effective for induction. However, patients need maintenance therapy because in theory, you're not going to be administering cyclophosphamide to the patient every 6 months. Tocilizumab did show improvement in the trial, here, yes, as an option for early diffuse cases with a high inflammatory burden, and azathioprine, as I mentioned, is an option for maintenance after cyclophosphamide, although it hasn't been shown to be as effective for induction. Moving on to the fibrosing component. In IPF, that is idiopathic pulmonary fibrosis or progressive fibrosing disease, the criteria for progression are that in the last 24 months, there has been worsening in 2 out of the 3 legs of the stool, meaning clinical worsening, spirometric worsening, or radiological worsening. Therefore, that is what defines fibrosing progression, which is not the same as the definition from the Census trial, which is actually the trial for nintedanib. And therefore, the conditions to be able to prescribe the only antifibrotic approved for IPF would be to meet 2 of the 3 conditions from the Census trial. That is what is required of us when it comes time to prescribe it. Therefore, nintedanib, as I mentioned, is the only antifibrotic with an approved indication in the official prescribing information. It can also be combined with other immunosuppressants. It has been shown to be completely safe, but remember that it has many side effects, especially diarrhea, also hepatotoxicity, and in fact even the manufacturers themselves recommend carob flour as a treatment for this diarrhea. And this is the algorithm proposed by EULAR. To begin with, mycophenolate, rituximab, or cyclophosphamide add nintedanib in case of progression or if the patient is already on the immunosuppressant. And, as a last resort, if there is no improvement, consider other immunosuppressants. And ultimately, if the condition worsens despite treatment, if there is a reduced or severely reduced forced vital capacity or pulmonary hypertension, consider lung transplantation. Joint involvement. I think all of us probably considered it the best first-line option, right? Methotrexate and other options, well, with other immunosuppressants that we use in clinical practice. Caution with anti-TNF agents and ILD because they can worsen it. It has been documented that they can make ILD worse. And regarding myopathic involvement, not the sarcopenia that all patients with sclerosis are going to have, but actual myositis, the inflammatory muscle involvement. Be careful with the dose of corticosteroids. The treatment is very similar to that of any other myopathy, but with two nuances. First, as I've crossed out here, do not use sustained milligram per kilo doses over time because of the risk of scleroderma renal crisis makes it preferable. It is much safer to use boluses. It's safer to administer 3-day boluses and then quickly taper corticosteroids down to 15 milligrams per day or less. Also, avoid calcineurin inhibitors due to the risk of developing a renal crisis. In cardiac involvement, fibrosis is much more common than inflammatory cardiomyopathy, although in cases of inflammatory cardiomyopathy, also look for an association with myositis. Early treatment is important, very important, not only monitoring fever, the left ventricular ejection fraction, and systolic function, but also diastolic dysfunction, which is one of the main causes of death in these patients. Mycophenolate and glucocorticoids, of course, yes, boluses, yes, but not high doses maintained over time. And other immunosuppressants have also been tried, which are described as effective. When it comes to fibrosis, the treatment is not going to be limited to this, it will also be targeted, depending on what is affected: valvular disease, arrhythmias. Thus, it requires joint management with cardiology. As for acute pericarditis, remember that not every pericardial effusion means pericarditis. This is a concept we sometimes misunderstand, and especially in scleroderma, many patients have at least a thin layer of pericardial effusion. In those cases, we need to investigate for both pulmonary hypertension and monitor blood pressure for a scleroderma renal crisis, which can cause the pericardial effusion. These patients, unlike those with other systemic diseases like lupus or RA, do not have such an inflammatory form of pericarditis. It is managed more with NSAIDs and colchicine, and not so much with corticosteroids, due to the side effects we've been discussing. It can be managed. Gastrointestinal involvement is multifaceted. Let's go step by step. As for osteotomy, our colleagues who will be discussing Sjogren's syndrome will explain symptomatic treatment much better. Regarding oropharyngeal dysfunction, it's important to remember that not everything in scleroderma is about the lower esophageal sphincter. The upper esophageal sphincter is also affected. Obviously, in this case, thickeners and rehabilitation are recommended. Moving on to the middle third of the esophagus, in cases of aperistalsis and also dysfunction of the lower esophageal sphincter, prokinetics are indicated. It's important to monitor whether the patient has an underlying rhythm disorder because of the possibility of making it worse. In gastroesophageal reflux disease, high-dose PPIs are the key. This is what you need to remember. H2 blockers like famotidine can help, or, in case the patient cannot tolerate PPIs for some reason, they could be an alternative. But, as I said, they are much less effective. Our goal is to use PPIs at the maximum dose. In Barrett's esophagus and esophageal strictures, aside from the fact that treatment is endoscopic, it's important to remember that Barrett's needs to be monitored. In dyspepsia, 3/4 of the time it's the same, PPIs and prokinetics. In gastroparesis, remember that it's not always caused by medication. There can also be underlying conditions, such as diabetes, that can worsen or predispose someone to develop gastroparesis. Prokinetics are also indicated. In antral vascular ectasia, patients with hematochezia or hematemesis, the treatment is endoscopic. In hypomotility, remember that it can cause pseudo-obstruction syndromes, treated with prokinetics. In cases of SIBO, small intestinal bacterial overgrowth, the first line of treatment, rifaximin, is commonly used, but the key is not which antibiotic to use, but to administer antibiotic therapy in cycles. We have to rotate the antibiotic when we retreat. And then in cases of constipation, aside from laxatives, remember that in cases of SIBO, lactulose-based laxatives should not be used. Why? Because lactulose is the test we use for diagnosing SIBO. If patients worsen after being given lactulose, we diagnose SIBO based on that, along with the breath test. So don't give lactulose to a patient with SIBO, as it will make the condition worse. And finally, in fecal incontinence, at the end of the digestive tract besides antidiarrheals, pelvic floor rehabilitation is very important, and in cases where nothing else works, then, a sacral neurostimulator. That's interesting. Immunosuppressants as such have not been shown to improve gastrointestinal involvement, but there are recent studies with the use of immunoglobulins that show improvement in cases of severe gastrointestinal involvement. Finally, moving on to scleroderma renal crisis. Obviously, 90% of cases will be hypertensive, and we initiate ACE inhibitors not as a preventive treatment, but as the actual treatment. The goal is to normalize blood pressure within 72 hours, but not too quickly, due to the risk of causing damage from lack of blood flow. And when I mention others here, I'm referring to adding medications. I'm not talking about replacing ACE inhibitors with another drug, but rather that we'll use all the medications we can to normalize blood pressure. In cases of central nervous system involvement, we'll use intravenous sodium nitroprusside with close monitoring. And if I focus on that, for thrombotic microangiopathy, then eculizumab, ravulizumab, and plasmapheresis. And now, to wrap things up, the up to hematopoietic stem cell transplantation won't be covered in depth either, but it's true that the latest British guidelines from 2004 do list it as an option. They list it as an option for patients with early diffuse ischemic sclerosis of poor prognosis, with severe skin, lung, heart, or kidney involvement. In other words, with very severe manifestations of the disease in patients under 65 years of age. The data, especially regarding skin involvement, are very positive, but it's important to remember that after 1 or 2 years, patients seem to start showing symptoms again. In other words, it's not a cure, it's about buying time. Buying time because, in addition, the mortality rate is high, so it's not recommended for all patients. And then, patients with a very low DLCO, very low FVC, pulmonary hypertension, or liver or kidney dysfunction, in other words, with involvement of other organs, paradoxically, it's not indicated for them. So, as I said, these are very carefully selected patients who could benefit from this